Good afternoon, everyone. We thank you for coming to spend a short period of your afternoon with the Black Health Trust. And we hope to provide you with useful information. As you know, the Black Health Trust was founded with the idea to bring vetted information from trusted messengers, physicians from across the country, to provide you with information to protect you and your family. And we hope to do that. And we've been doing it now for almost a year and a few months. I don't even know how long we've been doing this. But every Sunday we do it. Our co-moderators are Dr. Barbara Neighbors-Stevens, who will not be with us unless it's later. There's a House of Delegates meeting from the NMA. Dr. Ivan Walks, who I claim as my personal psychiatrist. Dr. Joycelyn Hines, who is a family practitioner in the state of Maryland. And we have a number of constant guests with us who will be hopefully commenting during the program. Dr. Wilbur Jordan, who's a specialist in infectious disease. Dr. Kenneth Steiner, who is a emergency room physician. Dr. Rhonda Johnson, who practices medicine in Pittsburgh. I started to say the state of Pittsburgh. Dr. Lisa Kerben, what's her last name?
Dawes.
Dr. Dawes, who's with us. Dr. Gary Dennis is usually with us. And there'll be others as we go on. Let's start out with our statistics. If you would show those, Simon, and if Dr. Walks would do the courtesy of just reviewing those.
Okay, thank you very much, Simon. Appreciate it so much. When we review the statistics, we're talking about the statistics that have to do with COVID-19. There are a lot of other Black health statistics that are prominent and critical, but we're focusing right now on the COVID-19 statistics. So as of this past week, total cases, as reported by the Centers for Disease Control and Prevention, over 79 million. 12.4% of these cases are African American. The new cases, 47,194. Total deaths are approaching 1 million, 955,135, and 13.7% of those deaths, or over 75,000, almost 76,000 of those are African American. And what always jumps out to me when I look at these statistics is that we are overrepresented in terms of the percentage of cases. If you look at the percent of the American population that's African American, and we know that's underreported. Even with that, we're overrepresented. And then we're even more highly represented in the percent of all deaths in this country. So clearly, this is a disease. This is a pandemic that has come for us in our community at a much more consistent and deadly way than it's come from any other communities. And daily deaths still 1,500 plus, even though all we hear in the news is, oh, we're on the downside, the pandemic is easing. Still over 1,500 people a day that are dying from COVID-19. Next slide, please. Thank you, Simon. In terms of fully vaccinated folks in the country, 216 million and of the total US population, and about 10% of that number is African American. So you can see when it comes to the illness, we're higher than our percentage in the country. When it comes to the number vaccinated, we're on the lower end. We can do better. Fully vaccinated and boosted in terms of the US population, 44% of those eligible to be fully vaccinated and boosted. And of that number, we are at an even lower percentage of 8.1% of the African American, of those are African American. So it's clear we've got work to do. Next one, Simon. Okay, this is a slide that we began showing several weeks ago, and folks can look at the slide. I won't go through every single one of these in any sort of detail. Suffice it to say that we have a significant mental health crisis that is linked to the pandemic. And so we talk about deaths from the pandemic. We talk about folks getting illnesses from the pandemic. We talk about long COVID in terms of what it does with folks from a physical health perspective. And this slide lets us know that clearly there are mental health consequences from COVID, as well as all of the other mental health, as well as all the other health consequences, general health consequences from COVID. Next one, please, Simon.
All right. Thank you very much, Ivan.
You're welcome, sir. Thanks, Simon.
So our topic today is do we still have to have concern about COVID-19? And we know that there's new information out about another variant, which is the nature of these viruses. And it is actually more transmissible than the regular Delta virus and even Omicron. But the prediction is that it is less deadly than those. So we're going to talk about some of that. But Simon, if you show the slides, starting at the one that says vaccine issues, I think that would be our good point to start our discussion. Okay. So on January 31st, 2022, the FDA, the Food and Drug Administration, granted full approval to the Moderna COVID-19 vaccine for persons aged greater than 18 years. So what is added by this report? On February the 4th, 2022, after a systematic review of the evidence, the Advisory Committee on Immunization Practices issued a standard recommendation for the use of the Moderna COVID-19 vaccine in persons older than 18 years of age. The CDC provided guidance that an 8-week interval between primary series doses of mRNA vaccines might be optimal for some persons. So what are the clinical implications for medical practice? This, in essence, is advising on the advice of practicing physicians that we recommend for people who might be immunocompromised in some way, that they get a booster. And by that, I mean having had either Moderna or Pfizer in 2 doses or J&J in 1 dose, that they recommend that you have a 3rd shot, which would be the booster shot. And that is the CDC recommendation. Let me open discussion amongst the moderators and physicians on that. this is where we currently are, and we're probably moving to even a fourth booster for those who are at more risk. Dr. Walsh, would you comment some?
Yeah, Dr. Maxey, happy to do that. I think one of the challenges for us is the messaging that comes out. Of course, we've talked about the fact that that folks are just saying things that are absolutely wrong. People are posting things on different social media and in general media that is just absolutely wrong, wrong-headed, misguided, what have you. That if that were the only problem, we'd be in a little bit better shape than we are now. But our other problem is that we use terms that are unclear for some folks. We keep talking about folks that are fully vaccinated, and the term fully vaccinated was based on CDC recommendations, right? We had these vaccines that came out, and they were vetted, and research was reviewed and all of that by the vaccine committees, the CDC, the National Medical Association, the Vaccine Committee for the Black Health Trust. And so the recommendation was, this is what you need to be fully vaccinated. We got the vaccine, it works best when you do this. And if you do this, you're fully vaccinated. And this was one shot of the J&J and 2 shots of either the Pfizer or of the Moderna mRNA vaccines. And so we got comfortable with that's what we mean when we say fully vaccinated. Now, if fully vaccinated is based on what's recommended by these entities about what people should do, that was clear to me. That made sense to me. But when the recommendations were updated as we got more information, we didn't update what that term meant. And so now we're trying to communicate to folks that, well, yeah, you're fully vaccinated, but we have this thing called a booster that we want you to get, as opposed to saying, well, this is what fully vaccinated now means. By the same people who recommended fully vaccinated before, we are now recommending fully vaccinated to be this. And we didn't do that. And so now we're talking about fully vaccinated plus a booster. And, I went to regular school. And if you tell me I'm fully vaccinated, why do I need a booster? It's confusing to some people. And I respect that, because I think words that we understand and we learn the meaning of, when you say fully, that means I'm pretty much done. So I think what we want to do on the Black Health Trust is to interpret and clarify to some extent, not necessarily what all the science says and what all of the politicians and all of that say. We really want to clarify and support what folks should be doing. And that's why one of Dr. Maxey's maxims is common sense. We really want to focus on what should you be doing, given who's saying what, and who shot John or whatever. How is it that we can fully protect ourselves and protect our family? So back to what Dr. Maxey just led with, we had confusion about emergency use authorization versus full approval. And then we had fully vaccinated, but now you need a booster. And the bottom line today is that folks should get their 1 shot of J&J or their 2 shots of Moderna or Pfizer, and then get a booster. And that's what, as I understand it, today means you're fully vaccinated. Now, I know a lot of people that have gotten that second booster, and so that's approved. At this point, I think it's recommended for folks that have immunocompromised and so on and so forth. There's discussion about whether people over 65 should get that second booster or whether everybody should get that second booster. And I think one of the things we can do on the Black Health Trust to be of service is that we can look at all of that and help people be clear about what it is that they should and we should be doing. Always starting off with, talk to your personal healthcare practitioner, your personal primary care provider, whether that's a physician, a nurse practitioner, whoever that is, but getting that advice, because that's the person that knows you the best.
So what are
I could talk for another 30 minutes, Dr. Maxey, but I'll stop there.
What are some of the things that constitute being immunocompromised in the broader sense, such as if you're diabetic,
Yeah.
you are at increased risk. In many
Dr.
cases,
Maxey,
yes.
I live in a state of confusion about all of these terms, and I try my best to make sure I understand it like everybody else is trying to understand it. So we talk about immunocompromised in some contexts as someone whose immune system is actually being ravaged by some large thing that we know about, somebody who has some cancer treatment, and so the immune system is actually being attacked in a real clear way because we're doing something to it. And then we forget sometimes, but not Dr. Maxey, some people forget sometimes that your immune system is compromised by chronic diseases, chronic illnesses like diabetes, as Dr. Maxey just mentioned. So I think, again, it takes us back to, how do I sort all this out? Well, the best way to sort it out is to, as Dr. Jordan always reminds us, have a primary care provider. So many folks don't have one. And then go see that primary care provider, and your individual health history, status, and all of that is wound into the advice you get from your primary care person.
So let me add some things that constitute my ideas of immunocompromised. Number one is diabetes. Number two, and this is not in order of preference, number two would be obesity. And obesity is defined as a BMI, and we'll talk about that later, of greater than 30%. Certainly if you're over 35%, and if you're over 40, you're morbidly obese. Now, some people look at a simple way to find out if you're obese. If for a woman, your waist size is greater than 34 inches, for a man, if it's greater than 36 inches, that constitutes obesity. The reason obesity gives you immunocompromise because it does affect your immune system. And in the case of COVID, it affects your cytokine generating system. So I would consider a large number of people in communities of color, for a list that's too long to read, potentially immunocompromised. And like Dr. Walk says, you should consult with your personal physician or caretaker and find out if you are immunocompromised. But I can almost say categorically, if you're Black or brown, have cardiovascular disease, high blood pressure, diabetes, obesity, and a number of things, certainly if you have things like lupus, you are immunocompromised and should consider getting vaccinated and boosted if your personal physician thinks you should. Simon, let's go to the next slide. And then we're going to come back and discuss some of it.
Dr. Maxey, let me just add, because I am one of those people that went and signed up at CVS to get my booster back when we first started talking about getting boosters. And I was told that we're not giving it to you because you don't meet the definitions that the CDC meets. And that's why the last comment you made about talking with your personal physician, who should be up on how you can get your shot, is someone that helps you, because you don't want to be like me and be the angry Black man at CVS because they wouldn't give me a booster. Reverend Pointer always, keeps me lifted up in prayer because I'm liable to be that angry Black man that we see walking around. So we don't want to tell people, go and do this. We want to tell people, make sure you contact your provider to make sure that you're eligible based on what's available in your community. Is that pretty clear, Dr. Maxey?
That's pretty clear. And don't you get arrested because I need my lithium. Okay, this is a table. I'm going to try to briefly look at it, and you can look at it too, Ivan. But it's a summary of the certainty of evidence of the potential benefit a Moderna COVID-19 vaccine in the United States. And in the first column, go to your left, and it says potential benefits, the potential prevention of symptomatic laboratory confirmed COVID-19. Moving to your right, the number of studies in this case was 1. Moving again to your right, the efficacy or the effectiveness of the vaccine Moderna was judged to be 92.7% efficacious. Dr. Walks, how do we use in common terms what efficacious means?
How do we commonly use efficacious to mean that it's effective? It like I'm 100% effective in lifting. My muscles have an efficacy of 100% in lifting something that weighs 10 pounds. When it weighs 100 pounds, my efficacy goes down, and the more it weighs, my efficacy goes down even more. So I like to understand things simply. Is it going to work to do what I want it to do? That's when I think of efficacy, that's what I mean. So is it going to work to do what I want it to do?
So this is saying in 92%, 0.7 of the people is going to be effective. But that also means it's going to be 7.3% not effective, I think, if I do that hard math. Is that correct?
Your math was correct, sir.
Okay. Good. And
that
the
includes people whose vaccine don't take.
7.3.
Okay.
That's okay. Close enough.
In 11 studies, and the pool efficaciousness was 89.2% effective. That still is pretty good, almost 90%. And the grade that they gave on the evidence certainty was 1. Let's go down to the next column. We're going to make a point of this, hopefully. In the prevention of harm, well, I'm on the wrong side. Simon, go back to number, that first slide. Okay, in the prevention of COVID-19 associated with hospitalization, there was one study, and it was 95.9% effective in keeping people out of the hospital. Then there were 15 studies of pooled data that shows that it was 94.8% effective in keeping people out of out of hospitals. And the quality grade of those studies was 2. Going to the next row, the prevention of COVID-19 associated death. There was one study, and it showed that 100% showed that it was effective in preventing death. Going to the pooled data, of which there were 5 studies, it showed that it was 93.8% effective in preventing death. And the grade on those studies was level 2. And in the last row, it says the prevention of asymptomatic SARS-CoV-2 infection. One study, it showed that it was 57.4% effective in preventing asymptomatic COVID. That's also saying that there was a large percentage that could still be symptomatic or asymptomatic, despite being vaccinated. And in 3 studies, it showed that it was 69% effective. So let's explain what this does. In terms of preventing hospitalization, it's extremely effective. In terms of preventing death, it's extremely effective. But in the sense of knowing that somebody took the vaccine, you don't know if they're still able to potentially transmit it to a large degree. You want to comment on that, Dr. Walks?
Well, Dr. Maxey, we had a question in the chat. Clearly it says on this table that this is from February of 2022, but what the question in the chat is, do these study results reflect the Omicron variant, which was circulating prior to that time, or are the studies themselves from before the Omicron variant began to circulate so widely, the Omicron surge, and are they significantly different from before the Omicron surge to where we are now?
Okay, my understanding, this was recently put out by the ACIP, which is a group that advises CDC and the FDA. And the director of the CDC, after hearing this evidence, has the ability to accept it and make it an official recommendation. And to my understanding, that's been done. And this is data from February of 2022. So it's the most recent in terms of the effectiveness of this. And some of this will be explained if we go to the next group, Simon. Next slide. And this is a summary of the, I think it moved. Can you pull it up just a little bit? Yeah, there. Summary of the certainty of evidence of potential harm of Moderna COVID-19 vaccination in the United States. And this says in the first row, characteristic potential harm that this vaccine can do, and it's pooled data in the first column. And it is saying under that, reactogenicity, serious adverse events. So the reactivity, there were 2 studies, and it was shown that there was a relative risk of 5.03 of serious, of reactogenicity, of having a reaction, of taking this. There were, I think 1 case in the next one I'm having trouble seeing. Moving down to serious adverse events, there were 2 studies, and it showed it was 0.92% risk of serious adverse events. The next one is potential harm by data source, and it says anaphylaxis, and that risk was 5.1, myocarditis, and that number was, they didn't come up with a percentage on that. And they were trying to divide men and women, so I can't speak on this so much because the numbers aren't there. But the key thing there is, I think we go further on this slide, Simon. Can we pull it up a little bit? So let's go back to the summary slide on this, the top, that there is a 5.0 chance that you're at risk for having a reaction to this vaccine.
So Dr. Maxey, let me just step in a little bit because I want to clarify what I'm seeing on the slide with you. Simon, can you go back down a little bit to that second slide? Thank you. So what there's clinical trial evidence on one side of the slide. On the other side is the observational evidence. And when you come down in that second from the right column, the one where the 5.1 is, it looks to me, and you can clarify for me, Dr. Maxey, that it's not actually a percent. It's 5 per 1 is the number of cases per 1 million doses. So 5 out of 1 million is way less than 5%. Am I reading that correctly?
You are.
Okay, I just wanted to clarify.
Thank you for the visual help. Thank you for the visual help. Then this makes even more sense to me. Looking at the myocarditis, then it shows that there were 65.7 out of 1 million. Is that correct?
So you're yes, you're right. In men ages 18 to 39, and then a much lower number for women. And there's also, I don't know whether you're going to be able to get to this or if they broke it out this way, Dr. Maxey, but there's a question in the chat about racial breakdown of some of this research.
I don't have that.
Okay.
But let's keep going. I got a few more slides and then we can discuss them all. Go down to the next one, Simon. And Dr. Walker, I appreciate your visual help. I'm struggling here a bit.
You're not struggling. That's why there are two of us. so we can work together. It's called teamwork, sir.
So vaccine side effects. What is already known about this topic? Cases of thrombosis with thrombocytopenia, meaning low platelets. And platelets are things that are the basis of blood clots in the body. And Guillain-Barré, which is a disease that affects your spinal cord and can lead to partial or full body paralysis. So a number of those have been reported after receiving the Janssen COVID-19 vaccine. What is added by this report? On December 16th, 2021, after reviewing updated vaccine effectiveness and safety, the Advisory Committee on Immunization Practices made a preferential recommendation for the use of mRNA COVID-19 vaccines over the Janssen adenoviral vector COVID-19 vaccine in all persons ages greater than 18 years in the United States. What are the implications for public health? Pfizer, BioNTech, or Moderna mRNA vaccines are preferred over the Janssen COVID-19 vaccine for primary and booster vaccination. The Janssen vaccine may be considered in some situations, including for persons with contraindications to receiving the mRNA from either Pfizer or Moderna. But they're saying there's a preference for being vaccinated going forward with Moderna or Pfizer. That's the recommendation of the ACIP. So people like one shot, which the Johnson & Johnson did, but they're saying that you can still use it if there's a contraindication for you getting the mRNA vaccines, but they are offering a preference for taking the mRNA vaccines. Let's go down to the next slide, Simon. Vaccines in children. What are the implications for public health practice? The Pfizer vaccine has high efficacy, greater than 90% against COVID-19 in children aged 5 to 11 years, and benefits outweigh risk for vaccination. Vaccination is important to protect children against COVID-19 and reduce community transmission of SARS-CoV-19. Let's go to the next slide. vaccine boosters. In the United States, 3 COVID-19 vaccines are approved or authorized for primary vaccination against COVID-19. What is added by this report? The advisory committee, or the ACIP, recommended for additional primary COVID-19 vaccine dose for immunocompromised persons in a COVID-19 booster dose in eligible persons. What are these implications for public health? Health care professionals play a critical role in COVID-19 vaccination efforts, including for additional primary and booster vaccination, particularly to protect patients who are at increased risk for severe illness. So they're saying that, like Dr. Walks was saying, originally we said fully vaccinated was your 2 mRNA or your 1 J&J. But now they're moving to say that you need a booster plus that. So fully vaccinated ultimately is going to mean the primary vaccinations plus a booster will now be the basement strategy going on. Let's go to the next slide and we'll discuss some of these. Vaccine rare side effects. Rare serious adverse events have been reported after COVID-19 vaccination, including Guillain-Barré syndrome and thrombosis with thrombocytopenia, which is low platelets. After Janssen 19 vaccination and myocarditis after mRNA, Pfizer, BioNTech, and Moderna vaccination. What is added by this report? In July 2021, the advisory committee reviewed updated benefits risk analysis after Janssen and mRNA vaccination and concluded that the benefits outweigh the risk for rare adverse events after COVID-19 vaccinations. The implications: continued COVID-19 vaccination will prevent COVID-19 morbidity and mortality far exceeding Guillain-Barré, thrombocytopenia, and myocarditis cases expected. Information about rare adverse events should be disseminated to providers, vaccine recipients, and the public. Let's go to the next slide. Vaccines in adolescents. On May 10th, 2021, the FDA expanded emergency use authorization for the Pfizer-BioNTech vaccine to include adolescents aged 12 to 15. That's my age group. What is added by this report? On March 12th, 2021, after a systematic review of all available data, the advisory committee made an interim recommendation for the use of the Pfizer-BioNTech vaccine in adolescents aged 12 to 15 years for the prevention of COVID-19. The Pfizer vaccine is the first COVID-19 vaccine approved for use in adolescents and has high efficacy against symptomatic COVID-19. This vaccine will be important to protect adolescents against symptomatic COVID-19 disease to reduce community transmission of SARS. Let's go to the next slide. See if there's one more. Okay, you can take them down. So these are all reports that I pulled off early this morning. And the conclusion is that we know that if you drink a glass of water, you can have a side effect. You can get choked or maybe drown. But the side effects coming from these vaccines, especially the mRNA, seems to be less. Is that number 0.5, Ivan?
Well, the slides are down. We just know it's tiny.
Very tiny.
We can use a word that I can understand. It's tiny.
Tiny.
Yes, sir.
Okay. And that our common sense of understanding tiny mathematics says that the risk of COVID still outweigh the tiny chance that something will happen to you from taking these vaccines. So if you never cross a freeway on foot, you're not likely to get hit by a truck coming down that freeway. So we continue to urge that you become vaccinated and boosted. We continue to say, given even the newest thing coming down the freeway with this new variant is more transmissible, that you continue to wear masks in the appropriate situations, that you continue to use common sense and use appropriate spacing if you don't know the people, you don't know the vaccine status. And if that one slide is looked at, where even if you're vaccinated, there's a high 40% something that person could be asymptomatic and transmit something even though they may have been vaccinated. So you should be aware that just because you're vaccinated doesn't mean you don't carry some risk of transmitting, even though it is shown that you may not get sick, you may not die, but there's still the specter that this can be transmitted in a vaccinated person to others, especially those that are immunocompromised. And I would venture to say that a high percentage of African Americans and Brown Americans have a condition that can lend you to be more vulnerable and have your immune system reasonably compromised, that you are at risk. So again, common sense. Are there any questions we need from the chat, Dr. Walks? And
Yes, let me say something. Can you hear me?
yes, Dr.
Dr. Jordan.
First, in terms of doing a study, I have to report every possible side effect. So if I'm doing a study comparing the use of penicillin versus water, if you have a reaction and it's water, I am still supposed to report it. So I think, we have to understand that anything that happens to any of the participants in a study is reported. Two, a lot of primary care physicians now are confused as to whether the person has had 2 shots, needs a booster shot, etc. I've had 3 referrals recently because one of the patients went to their doctor, said they'd had a shot, wasn't sure whether they wanted to get a booster or needed another shot. So it was sent to me. I think the language that we're using, if I've had 1 shot, do I need another shot? But we're saying a shot, then when it comes to a booster, it's like it's something different. In most cases, the same amount. So, I think that's a problem, as well as how we communicate these things to primary care physicians. So I hope we can still make it very clear that we think people need to get vaccinated. Vaccination is the easiest and simplest way for the individual to have protection as well as not spread the infection to other people.
Dr. Jordan, I'm sorry. Dr. Jordan, let me just clarify. you said that a patient went to their physician and the physician referred them to you, another physician, to ask the
Yeah.
question about, can you tell a little bit more about what do you think happened that that other physician needed to refer to you to ask
He
the
didn't
patient a
understand the
question?
difference between booster and shots. You have to
Oh,
remember
my.
in cities that a lot of physicians, how do I say this to satisfy your political sensitivity? A lot of them, English is their second language.
Okay.
And they really don't
okay.
understand things. And that becomes an issue in terms of where you're going. And again, a lot of patients, depending on what kind of insurance, if they have insurance, don't have much say in terms of who they're going to.
Right.
So they may get someone who really doesn't understand English that well. And you go in and say, you've had one shot, you want a booster. When you can't get a booster, you have to have a second shot. And he doesn't understand, well, let's give him the shot. That's the language we are going to be facing soon, is trying to help providers understand that, because many will not. And that's where our relationship with the NMA, I think, is very important. And they're meeting next week, the colloquium. But I think we need to be doing things to make sure, and we don't just need NMA members, we need to be trying to do something to reach physicians who treat minority patients across the country, whether they're in the NMA or not, I don't care. Many are not. But we need to be doing things, and we need to realize many don't understand the language that they're seeing now. And when you think about it, it makes sense. Can you give me a booster if I've only had one shot? You have to understand that.
So,
And many patients don't know how many shots they've had.
so let's come out with a recommendation. If
Yeah.
you are taking Moderna or Pfizer, everybody knows those names by now, being fully vaccinated includes 2 regular shots plus a booster shot. All those shots are the same. There's no difference in the primary shot, the first one you get, the second one you get, and the third one you get. There's no separate booster shot that has a different label on it. So we're clear right now that a series of 3 shots is what is needed at this point. And we're right on the brink of adding number 4 to that regimen. But all 4 of those shots are exactly the same in composition. Is that clear?
Yes.
Number 2.
But we have to be clear that a lot of our patients, now Randy, you have treated people with syphilis. And I know you have asked some man, how many shots did they give you? And they may have gotten 3 and they may remember 1. Or they may have gotten 1 and they'll sit there because they don't want to get a shot anyway. And they're, are you going to give me a shot? I just yes, you're getting a shot. A lot of people don't really remember those things. I mean, that's
but I'm trying to clarify. I'm trying to clarify for our audience today, which is not physicians.
So but for our audience today, what you're saying is right on target, clarify, etc. I just think we need to look at having recommendations of saying things to really help providers out there know, understand things, and also
and we'll do
work
that.
with pharma to really reach patients.
Okay, let me finish my recommendation. If your first vaccination for COVID was the 1-shot treatment with J&J, Johnson & Johnson, the clear recommendation is that your next shot, your next vaccination, your booster should be either Moderna or Pfizer, unless there's some contraindication for you getting one of those 2 particular shots. The 1 vaccination with J&J, the Johnson & Johnson, is not sufficient as a standalone. it requires at the very least another vaccination or booster, if you will, from one of the mRNA vaccines, unless you have a contraindication based on an allergy or something to that, then it would be acceptable to get a booster done with the original J&J that you had. So that is the current recommendation.
Very well said.
Okay. And let me move to one other part that we didn't address. For those who have children, there was a vaccine approved for those 12 to 15. There was another vaccine approved for those 5 to 11. So a question was raised that many of those who are 11 years old are physiologically 12 years old. But the dose they've been assigned is 30% of what the 12-year-old get. And I don't believe that they have officially addressed that yet. Again, your personal physician can, in his or her judgment, help you over that. But if you got a 6'4", 11-year-old, that doctor or provider may want to consider whether the adolescent dose for those 12 to 15 should be considered in that kid who's right on the cusp based upon his physiological and size development. And if there are any pediatricians on the call, sorry, Dr. Neighbor isn't on right now. But no, Dr. Steiner, you're emergency room. Dr. Johnson, you do public health. I'd like, and Dr. Lisa Kervin-Dawes, you see a lot of patients of all age groups. I'd invite you to unmute and comment. And of course, Dr. Walks, of course.
So let me just make a quick comment, Dr. Maxey. One of the challenges with us telling folks exactly what to do is that it's not always exactly simple. If you, as I just did, I just typed into my phone while we were here, is the booster shot the same as a third dose? So let's say you've had your Moderna first and second doses, and then you go for your Moderna third dose. Well, if you're immunocompromised, you may be recommended to get a full dose, but if you're just getting a booster, it's a half dose. If you got Pfizer for your first and second shot, the Pfizer booster is a full dose, not a half dose. So I want to continue to emphasize how important it is for us to make sure we're getting good advice from our primary care provider, because that's the person that knows us the best, and that should be the person that understands some of the nuances of what's going on with getting your shot and getting your booster. And the last thing I'll say before I stop is, one of the things Dr. Jordan said is really, really important. It's not unusual. When Dr. Jordan is talking, he's usually making a point that we need to pay attention to. Here's another one. Dr. Jordan said, what I heard, I don't know what you actually said, Dr. Jordan, but what I heard is that you said some doctors don't communicate effectively with their patients. And that's true whether English is a first language or second language or any kind of language. Sometimes there are cultural differences, and we all come from the same place, but we're raised differently. And so making sure that you take time as a physician to understand what your patient is trying to communicate to you is important, even if you're from the same neighborhood. And also, as importantly, as a patient, advocate for your doctor to clarify to you that they understand your question. Ask the doctor, is it clear what I'm saying? I really want to communicate to you that I'm thinking about this, or I'm worried about that. So Dr. Jordan, your point about that interface between the patient and the provider and it not being a place where everything is clear, That's huge, man. I mean, that's the whole root of what we're trying to do. We're trying to get a clear communication about a problem and an intervention. And if the mess up happens there, it doesn't matter what we're talking about. So Dr. Jordan, thank you for pointing that out, that we've got to start with clear communication. And then Dr. Maxey, back to the every shot is the same shot. It really, it's a little more complicated than that.
Well, in the sense of communication, and as a practicing physician who's suggesting that you go to your private physician for final advice, to be clear, I recommend that if you've had Moderna, you still need a third shot. And it is exactly the same as your first two shots. And I don't care what comes up on the internet. I'm telling you what I believe you should do, and to talk to your physician about it. Yeah, I can't advise you here on the Zoom call. If you've had the J&J, that is not alone sufficient. And your second shot, if you've had the one shot J&J, should be a Moderna or a Pfizer shot, and that will put you in better stead. Unless you're allergic to one of those two, then that second shot could be a J&J shot. That is the current recommendation from all the literature that I've looked at for the past several days. If you have further questions in depth, you can go to your private physicians. But that, I believe, is the best way to get around the communication deficits coming out, where they say wear red on Tuesdays and it'll fix your disease. That's crazy. Are there any questions in the chat room?
There are not other questions in the chat right now, Dr. Maxey, but there's some good information that some of our participants have posted in the chat. So I would recommend that everyone look through the chat and look for some of that information, because it supports what Dr. Maxey has been talking about.
Dr. Maxey, could I clarify the issue around the pediatric dosing?
Yes, ma'am.
Okay, so the point that I want people to remember, there's only one formulation of these vaccines that are approved for children. That is the Pfizer vaccine. So that's point one of clarification. Moderna and Johnson & Johnson, you have to be 18 years and up to get Moderna and Johnson & Johnson. Now, for the Pfizer dose, there are two different recommendations for children. Children 5 to 11 receive a dose that is 1/3 of the adult dose for the 5 to 11. So the American Academy of Pediatrics, which I'm a member of, has given a lot of training to pediatricians. There have been a lot of effort to educate pediatricians because this is a common occurrence. So let's say a child comes in that is 11 years old, and a month later they will turn 12. Okay, so the Pfizer dose you give 21 days apart, regardless of what age. The primary series is 2 doses separated by 21 days. So when the child is 11 years old, it doesn't matter the size. If that child is 11, period, they get the 5 to 11 vaccine. Now, when they come back for their second dose, let's say they've had their 12th birthday, then they get that dose that's approved for 12 and up, period. You don't repeat the dose. So I just wanted to clarify that for the children, it's very, now here's the dilemma. Many people do not get their vaccines, their COVID vaccines, at a doctor's office. They get them at these vaccine fairs in community settings. They get them at churches. They get them in the home for the seniors, maybe in the high rises, or they get them at the pharmacies. But a lot of times they do not get them in the doctor's office. However, every vaccine provider should be approved by their state health department. I'm not sure all 50 states how this works, but they're supposed to be trained and they're supposed to have quality assurance. so these community sites know how to give the vaccines. Having said that, I can tell you for certainty, there have been a lot of errors in vaccine administration since this was rolled out, particularly in the beginning, when the effort was to give as many people shots as possible. But the good news is that these vaccines overall are so safe. Their side effect profile is very on the safe side as opposed to on the serious adverse events. It is sad if you're the one that has Guillain-Barré. It is sad if you're the rare person that has anaphylaxis. It is sad, if you're the one that has myocarditis. That doesn't minimize the fact that you had a serious adverse reaction. But the vast majority of people do not have these major serious adverse reactions. And that's why these vaccines are easy to give in the community setting, because most people do fine. I can tell you, most children get their shots and they go to band practice. I've seen teenagers, I've seen boys, they go immediately to football practice. It's like they tell you, it's like I didn't have a shot at all. These vaccines have been very well tolerated, at least in the short term. Now we have 2 years of data. There are 11 billion vaccine doses around the world that have been given in people's arms. So, and there are a lot of different vaccines. There's at least 5 or 6 vaccines that are used around the world. And overall, these vaccines have been safe as far as we know. Again, a lot of the reporting goes through the VSafe, which is the online, and the VAERS, which is, all of these are self-reported, but that's the data that we have.
Very well, sir. Thank you.
So Dr. Rhonda Johnson, would you introduce yourself to us so we know who you are? And we're looking for you to come on one Sunday and give us a presentation. But would you introduce yourself?
Hello, I'm on the medical advisory committee, but I don't often go to the Wednesday meetings. I just wanted to apologize. They're at 8:30 or something Eastern time and 5:30. And I'm not in the mood to be meeting at 8:30 at night, Dr. Maxey. I just have to apologize. I just don't have that bandwidth to start a meeting at 8:30.
Yeah, but would you introduce yourself kindly so everybody knows who you are?
Okay, yes, I'm a pediatrician by training, and I have a master's in public health. I've worked for health departments, and currently I have retired from active clinical practice, although I do healthcare consulting in the public health setting.
Well, thank you for your astuteness and giving us this information, and we're looking forward to featuring you in one of our programs.
I'd like to support Dr. Rhonda Johnson's complaint about the meetings being late at night for those of us on the East Coast. Reverend Pointer, feel free to support Dr. Johnson and I about these 8:30 at night meetings.
We will give you an hour. I can do 4:30.
Anyway,
Okay.
But I digress. Please, Dr. Maxey, go ahead.
Okay. Dr. Kenneth Steiner, you're an emergency room doctor, and you know people who see all of us.
Yeah, sorry, Randall, I just got a call. I'll be right back to you.
Okay. Then lastly, Dr. Kervin Dawes, what's going on with vaccines and the situation in Jamaica? Dr. Kervin Dawes?
I see Dr. Kervin Dawes on. I see one of her spots is on mute, so I'm not quite sure if she's able to respond at this point.
Okay, well, we're counting down to our sign-off time anyway. It's about 1:12. We've got just a few more moments. I was hoping that Dr. Barbara Neighbor was going to join us, but she's involved in the House of Delegates for the NMA, so she's out there protecting our interest.
So Dr. Maxey, I think one of Dr. Johnson's comments is really at the heart of this whole conversation, which is folks saying that they're concerned about the safety of the vaccines, and Dr. Johnson shared with us that clearly the vaccines are safe. But where you started us today, Dr. Maxey, was with this evidence about the safety of the vaccines. And Dr. Johnson said, well, the risk is very, very low. And we talked about the risk. Actually, we use that scientific term, tiny, that the risk is tiny. Okay. But people still want to feel comfortable that, well, but what's the risk of me getting sick and having a bad outcome from COVID if I don't take the vaccine? And that's the one part that I think we haven't quantified today. So we've given numbers about so many people are dying from COVID still, and we've given numbers that African Americans are overrepresented in the population of folks who are dying from COVID. And Dr. Maxey, you shared with us some of the reasons for that: the diabetes, the obesity, our poor health status in general, that don't allow us to present our healthiest body when something comes to get us, whether it's COVID-19 or the flu, right? So there's something about that risk that people seem willing to take. Well, I'm just going to try to not get it. I don't want the vaccine. The risk might be low, but I'm still scared. I don't trust it. And I don't think I'm going to get sick if I get COVID-19. And we have to be willing to take that part of it head on. Yes, if you're a healthy person, you might not get sick and die from COVID-19. But oh boy, what if you are that one of 1,500 people that died from COVID-19 yesterday? What if that's your loved one that died from COVID-19 yesterday? It allows us and forces us to go back to some of the common sense questions that we ask people about washing hands and keeping distance and wearing masks and all of that. And the vaccines are one other thing that we do to protect ourselves. And just like people say, well, I can't wear the mask, I can't breathe. No, the mask is not going to kill you. 100% sure that you're not going to die from wearing a mask. We know that. We are also very, very sure that the risk from the vaccine is tiny, and the risk from getting COVID-19 is not tiny. And your risk of having a bad outcome from COVID-19 is not tiny. So we got to take that part on. And I don't know if maybe we can look for some numbers about exactly what is the risk of you dying, so we can really compare apples to apples. Does all that, I know I ramble a little bit, I'm sorry. Does all that make sense?
No, it does make sense.
Unfortunately,
And we should look for those numbers, and we'll try to have them by next
Dr.
week.
Maxey, I haven't read the study yet, but the New York Times published an article that said Black adults were hospitalized at 4 times the rate of white adults in the 6 weeks after Omicron. So during this recent Omicron surge, Black people were hospitalized 4 times the rate. Now, the CDC published a study in the MMWR Friday, so I have not had a chance yet to read this, but this is something that we should know about, because we are facing yet another Omicron wave. And we, as you showed us in these statistics, we know that our people are under vaccinated and under boosted. And what is very concerning is the number of elderly people who are not boosted. Only, they say 1 out of 3 eligible people that are 65 and up have been boosted. And looking at what's happening in China and Hong Kong and the UK, the elderly are experiencing a horrible, in Hong Kong, the elderly people are dying. In UK, 85 and up and 65 and up are being hospitalized right now with BA2. So we really have to push vaccination and boosting in our elderly community, 65 and up. We've got to try to do a blitz to get information out there in the next couple of weeks, because Omicron is doubling in the United States, even though we're not talking about it. You know, the CDC publishes the data, but we're not hearing it on the news. Wastewater surveillance data shows it's up 1,000% in a number of communities up in the United States. And the CDC's own website says Omicron BA2 is hitting New Jersey, 38% of infections in New Jersey, a state that has a lot of African Americans, is Omicron BA2. So we're about to get hit again with another serious Omicron wave. And our people are going to be very susceptible because we're under vaccinated and under boosted.
I love
Well
what
said.
you say. Reverend Pointer, and I'm going to refer to you as Dr. Pointer. I want to pose a medical spiritual question to you. I have a number of patients who are Christian in faith, and several of them claim to have the gift of prophecy.
Oh, Lord.
And they have noted to me that they will not take the vaccine until they have a personal communication from the God of the universe. And one of them came into my office, a very good friend of mine. She's 5'7", 265 pounds, unvaccinated, and she brought her 75-year-old father with her, who is vaccinated. How should I approach people like that? And these are actual people. And I believe very much in prophecy. I believe very much in getting the word from God. But should people expect that in every incident that they have a personal communication with God to tell them what to do with their life, which affects others?
Dr. Maxey, keep your black suit ready.
Mm. Wow.
Because look, God gave us science. And when we deny science, we can't possibly be a believer and deny science, because science is a product of what God has given us. And these ideas that God is going to send us a different kind of rescue than the one that he has already sent us is to say that he hasn't sent us anything. And that is not the case. It's amazing because I covered this in this morning's sermon. I preached Psalm 17 today. And the questions I asked the congregation were a series of questions, not about their faith, but about their sense of self. I mean, which one of us is in the position to say what God has not done when we're looking right at what God has done, when the evidence is in front of us? And so when I hear people using their faith as an excuse to abandon common sense, I'm alarmed. And I would tell you, keep your black suit clean, because those are people who are going to succumb to this disease, and the pain of it will be awful to you, because it's awful to me every time it happens. But you can't convince people what they should know based on common sense. I mean, we need Dr. Nabrit here today, because she is the Black Health Trust herald of common sense. And common sense says, if I'm looking at something, I can't deny that that's from God, because everything comes from God. So when I hear people having these discussions, I'm questioning that. The other thing is, and this is about what I learned as I'm continuing to study the scripture, and even now as I'm completing work on an additional degree. What God has done in the past is never altered. It's already done. So you can't by your rhetorical wizardry undo what God has wrought in history. It doesn't change simply because you believe you're a prophet or a prophetess. I'm not a prophet, but I operate in the prophetic mantle. I can find no evidence that prophets have been extended to us outside of the apostolic age. That's not to say that the prophecy isn't there, because it's right in the scripture. So the prophecy still exists. But for me to stand and tell you I'm going to prophesy over you, if I'm not sharing with you the word of God as we have canonized it, I would My pastor told me, son, take that with a grain of salt. God, if he wants to deliver you a message, knows exactly where you are.
Thank you.
So
Yes.
Dr. Maxey, can I follow up on
Sure.
that? Reverend Pointer, I remember going to church and hearing the story about the person who was caught in the flood and sitting on the roof and praying to God to come and rescue them from the flood. And then the person in the boat came by and they
Mhm.
said, no, I'm not getting in your boat. I'm praying. I'm waiting on God to come and rescue me. And then the helicopter came by and they said, no, I'm waiting on the helicopter. I'm waiting on God. I don't need your helicopter. And when they finally died and said, God, why didn't you come rescue me? God sent, I don't think God said these words, but the rest of it is, I sent your dumb behind a boat. And I sent your dumb behind a helicopter. So I sent your dumb behind some vaccine.
Thank you.
Exactly.
Well
Exactly. That's
said.
exactly the point. And I'm telling you, when people do these somersaults that suggest that we are waiting for some divine intervention while we already have it, I just get my clothes ready because I know they're not operating in common sense.
It is sad. So Dr. Maxey, there's one other um, practical question in the chat.
Yeah.
Someone is asking about how often they should take a COVID test, even if they're fully vaccinated. And given all of the data that you shared earlier, there is a role for continuing to take a COVID test, even if you're fully vaccinated. So if you want to take that one, or I can take it.
Okay, you can start off and then I'll come up
Okay.
with you.
Well, my understanding about COVID tests, and somebody else can correct me if I'm wrong, is that we really want to take the rapid test. We want to know if we are infectious at this point, especially if we are fully vaccinated. And your rapid test is good for right now. Your rapid test means that right now today, you're not shedding COVID-19. And so how often should you take one? I think anytime you find yourself in a situation where you've either been out, like if you like to go out to dinner, you went out to a restaurant, a couple of days later, stay by yourself and take a COVID test. Or if you're getting ready to go someplace and interact with other people, make sure you're not going there while you're actively spewing COVID. So you can't test too often. And if you've been at home by yourself for just because 2 weeks have gone by, doesn't mean you need to take a COVID test. So I'm assuming the question is for someone who is vaccinated and not symptomatic.
Okay, let me add to that. There are two types of tests. There's a rapid test that can tell you if you have an active COVID event or infection going on. And that is a test to show that the virus is there. The other test, which is a PCR test, can tell you if you've had exposure, and it's an antibody test. That test is good, but it can be positive long after you're not infected. In fact, it can go up to 2 months, I understand. What I require for a patient to see me in my office is that they either be vaccinated and boosted, because I'm 200 years old, or they have to show me evidence from an entity that does this commercially or for the government within 48 hours that they have had a negative rapid test. I don't accept a home test to come to my office. And then even when you come to my office, we seat you so that you're socially distanced. We spray your hand with sanitizer or 70% alcohol. And then when I see you, for the most part, we have social distancing. I think all the time about these ophthalmologists who use slit lamps. I'll let somebody professional comment on that, where they're right in the face of a patient. And I wear gloves while I'm doing my physical exam. And so for those of you who are physicians, just because we're doctors doesn't mean we don't have our own vulnerability. Those are my thoughts. I hope Dr. Walks agrees with that.
No, I certainly agree with that, Dr. Maxey. And once again, looking in the chat, thank you. Dr. Johnson has put some good information in there. Beyond what you said about how you handle things in your office, and again, I'm not trying to do a commercial. I'm just telling you what I do. I have one of Mr. Dorsey's machines in my office. So when you come in the door, in addition to the screen that we have up and the hand sanitizer that you have to use and the temperature that we take, we have one of those machines in there. So I am pedaling as fast as I can because, as Reverend Pointer said, the Lord made all of that stuff available to me. So I'm going to use all of it.
Well, that's good. And Mr. Dorsey, we sure appreciate what you brought to the table. And we're using that, and I'm going to order some more real soon. Maybe the next 2 weeks, I'm going to order 5 more of those machines. And I'm suggesting other people look at it and get it for their homes and their offices. And I got a new grandbaby. I made sure he had one in his house because I don't want no stuff about my little grandson getting hurt. Is Dr. Lisa Dawes on? Did she come back?
I see Dr. Dawes is on. I don't know. You know, Dr. Dawes is doing real work on Sunday afternoons in Jamaica. Her role as being responsible for a lot of infectious disease down there keeps her busy. So she's always on with us, but sometimes she can't stay right by the phone or by the Zoom call.
Okay. Well, I think we're at the time when we're going to sign off. And I invite Dr. Johnson, Dr. Jordan, and of course, Dr. Walks to have a final word. Dr. Johnson?
I don't know what happened to my video. Am I on? Okay, here we go. Well, my only final word is from someone who has had COVID. You don't want this disease. You don't want it. And if you can do anything to prevent it, prevent it. And we're not going to be able to vaccinate our way out of this pandemic, in my opinion, because these variants are too contagious. Omicron is just too transmissible and it spreads very fast. And we keep getting more and more variants. And so we have to use the multi-layered approach. We have to continue masking, continue washing our hands, continue distancing, and continue wearing the best quality mask you can wear. And get the vaccines that you need and get the boosters that you need, but put on that, N95 or a KF94 mask, whatever you can get your hands on, but up your mask game and continue to be vigilant. We can't live in fear and we can't be isolated for the rest of our lives. We have to continue to live with this pandemic, but we try to live as safely as possible.
Well, thank you very much, Dr. Johnson. Is Dr. Helen Davis on? She's the person who actually introduced me to Dr. Johnson.
I don't see her, Dr. Maxey.
Okay. Dr. Wilbur Jordan, final words.
I was with a community group in Fountain Valley, and 3 families, all large, and no one wanted the vaccine. About a week later, one of the members in one of the families got very sick, was hospitalized, and died. And that brought a lot of guilt on the part of the other members, but we were finally able to get everyone to get a vaccine then. It's just a damn shame that someone had to die to get people to get a vaccine. I think we all have a role just to try to be as much a part of our respective community groups as possible. And I just think at times, we're going to lose some, but we have to continue to encourage people to get a vaccine. If I'm vaccinated, I may be exposed to the virus, but the chance that I'm going to get really sick is slim. So it's important for us to encourage people to get the vaccine, the same as with the flu. And that's my final word, and thank you.
Thank you very much. And
Maxie?
to Mr. Dickerson, I'm still interested in the gentleman that you work with, whose daughter is a friend of Dr. Walk's, coming on one Sunday and giving us a view from his viewpoint. His daughter is, I think, Serena or Sarita, Dr. Walks. We've been on her broadcast
Um,
out of Chicago.
I'm not sure exactly what we are talking about, Dr. Maxey, so you and I can talk about that offline.
Okay.
Okay.
Final words, Dr. Walks.
There was a question earlier regarding folks who have to take periodic shots and have Crohn's disease and how that relates to booster shots. And I would just say that when you have a specific case that may not fit into a general recommendation, such as can this shot be taken when you're taking a shot for Crohn's? I'm assuming maybe it's a steroid shot or something. I don't know, because I don't know the case. I don't know the patient. And asking a psychiatrist about Crohn's disease is definitely should not be your final word anyway. So I think my advice is, again, to go back to where Dr. Jordan leaves us all the time, or leads us all the time, is make sure you take a lot of these recommendations back to your primary care provider, back to your pediatrician, back to your family practice doc, and make sure that you're getting advice on those specific incidences or cases from that person. I can't
Your primary
override-
care doctor, your
Right.
primary care doctor should know that, and Crohn's is not a reason to not get the vaccine. But if your primary care doctor is worth anything, he or she should know that. But that's what
it was. Yeah, Dr. Jordan, it was more a question about the timing of the shot. But again,
Right.
your answer is the same. Your primary care doc ought to know that. So I think, Dr. Maxey, for me, my final word is that we have a significant opportunity here at the Black Health Trust to get good information from credible experts. And I'm really excited for the folks who take advantage of it. I'd like to encourage folks to let other people know what we do on Sunday afternoons, and to continue to put some tough questions in there for the chat, and continue to let other people know that there is a place they can go to get information that may be better focused on them and on the needs of our community. Thank you, Dr. Maxey.
Yeah, thank you. And if the person who wrote that question wants to communicate and give me that question, one of our medical advisory committee is the chairman of gastroenterology at George Washington University. We can certainly put that question to her, and she is super sharp. And my last word before we get to Pastor Pointer taking us off. Brenda's not on this sheet, Ivan.
I don't see her, no.
Okay. We hope that you take the recommendation seriously. We will have this information posted in a few days on our YouTube channel and Facebook. And we advise you to follow the directions given to you last week by Dr. Suzanne Cutter about protecting your health by having a good diet, by having appropriate exercise, getting as close to 8 hours or more sleep that you can get, and of doing the social distancing and wearing protective covers around people that you don't know or you suspect. And we believe that a strong faith life is also helpful to you. Dr. Pointer, would you take us out?
I think Dr. Pointer just dropped off. I think he may have had some technical challenges. So Reverend Maxey, would you take us out?
Most Heavenly Father, we thank you for all that you have done for us. We elevate your name. We thank you for your protection and for imbuing us all with a healthy dose of common sense. Thank
Amen.
you. Everybody have a good afternoon.
Amen. Thanks, everyone.
And thank you, Simon, again.